If you have PMOS, what most people still know as PCOS, there's a good chance your management conversation went something like this. Eat better, exercise more, here's a prescription, and come back in 3 months. And if you followed that advice and still felt like something wasn't adding up, you're right. There's a lot the standard conversation leaves out, so today I'm going to cover 7 of those gaps, with the mechanism behind each one so you understand what to do and why it works. Stay until the end because the last one involves your evening light environment, and it's one of the simplest changes on this entire list with one of the most direct connections to the hormonal dysregulation driving PMOS. I'm Dr. Kabir Haricharan Singh, a physician who's board certified in both family and obesity medicine, and before we get into it, here's a quick disclaimer. Even though I'm a doctor, I'm not your doctor. This is educational information only, not personal medical advice. Always discuss decisions about your health with your own physician first. Insight number 1, your gut microbiome may be driving your androgen levels. The gut's connection to PMOS is one of the most rapidly evolving areas in the research literature and one of the least discussed in clinical practice. Your gut microbiome produces an enzyme called beta-glucuronidase, which breaks apart estrogen and androgens in the intestine, allowing them to be absorbed into circulation rather than letting them be excreted. In women with PMOS, research is now consistently showing a significantly altered gut microbiome with reduced microbial diversity and specific shifts in bacterial populations that increase beta-glucuronidase activity, promoting androgen recirculation. A landmark study published in the Journal of Clinical Endocrinology and Metabolism found that women with PMOS had measurably distinct gut microbiome profiles compared to controls, with specific reductions in lactobacillus and bifidobacterium species, and significant correlations between microbiome composition and androgen levels, markers of insulin resistance, and the severity of PMOS features. It also found that the gut microbiome isn't simply altered by PMOS, but may actively contribute to its perpetuation. A subsequent systemic review confirmed that probiotic supplementation, specifically strains targeting the microbiome disruption observed in PMOS, produced significant reduction in testosterone levels, fasting insulin, and inflammatory markers compared to placebo. So these studies showed that supporting gut microbiome diversity may be a direct androgen and insulin management strategy in women with PMOS. To do this, prioritize dietary fiber diversity, 30 or more different plant foods a week, which research shows is the most powerful predictor of the gut microbiome diversity. Include fermented foods, yogurts with live culture, kefir, kimchi, sauerkraut, miso. Minimize ultra-processed foods which consistently reduce microbial diversity and shift microbiome composition towards inflammatory profiles. Consider targeted probiotic strains, specifically Lactobacillus acidophilus and Bifidobacterium species, which have the most consistent evidence in PMOS-specific research. Insight number 2, the type of exercise matters more than the amount. Most exercise recommendations for PMOS focus on the amount of physical activity, usually 150 minutes a week of moderate intensity exercise as per standard guidelines. That target's not wrong. It's incomplete in a way that matters significantly for those in this specific population. The detail most people are never told is that the type of exercise produces dramatically different metabolic effects in PMOS. Skeletal muscle is the primary site of insulin-mediated glucose disposal, accounting for approximately 80% of post-meal glucose uptake. But within skeletal muscle, type 2 muscle fibers, your fast twitch fibers, can clear sugar from your bloodstream without relying on insulin, which means the more of them that you have and the more you activate them, the less work your pancreas has to do and the lower your insulin levels stay. Your body only uses these muscle fibers when things get hard. That comfortable pace on the treadmill you've been doing for months, it's barely using them. But the moment you pick up something heavy or push yourself into an uncomfortable zone, they engage. And that engagement is where the insulin-lowering magic happens. A meta-analysis published in Reproductive Biology and Endocrinology specifically compared exercise modalities in PMOS and found that resistance training and HIIT, high-intensity interval training, produce significantly greater improvements in insulin resistance, testosterone levels, and menstrual regularity compared to moderate intensity continuous training. So if your primary exercise is walking, yoga, or light cycling, these are beneficial and worth continuing. but they shouldn't be the primary modality if your goal is addressing the insulin resistance and androgen excess that causes the symptoms of PMOS. Progressive resistance training 3 times a week and 1 to 2 HIIT sessions a week should be the core exercise prescription for PMOS, with moderate steady-state cardio as a complement, not the foundation. Insight number 3, your circadian rhythm disruption may be worsening your hormonal profile. This is the insight that connects 2 things most people would never think to connect: your light environment and your androgen levels. Your circadian rhythm, your internal biological clock, regulates the timing of cortisol secretion, insulin sensitivity, and sex hormone production through master clock genes in a part of the brain called the hypothalamus that are synchronized primarily by light exposure patterns. Research has now established that women with PMOS have measurably altered expressions of core clock genes, dysregulated cortisol awakening response, and disrupted melatonin secretion timing compared to women without PMOS. The disruption runs in both directions. Insulin resistance and androgen excess disrupt circadian signaling, and disrupted circadian signaling worsens insulin resistance and amplifies androgen production, because the enzyme involved in androgen synthesis in the ovaries and adrenal glands are under circadian regulation. Practically, this means that irregular sleep-wake timing, late-night light exposure, and inadequate morning light exposure are not simply lifestyle issues for women with PMOS. They're active contributors to the hormonal dysregulation driving the condition. So here are some modifications that are free, immediate, and mechanistically connected to the hormonal environment of PMOS in a way that's rarely communicated in clinical practice. In the morning, get 10 to 30 minutes of outdoor light exposure within 1 hour of waking, without sunglasses and before screens if possible. This anchors the circadian clock and optimizes the cortisol awakening response. In the evening, minimize bright artificial light, particularly blue spectrum light from screens and LED overhead lighting, in the 2 hours before bed. Blue light suppresses melatonin onset and delays circadian phase, which disrupts the overnight hormonal recovery cycle. Finally, maintain consistent sleep-wake times, including the weekends. Circadian disruptions from irregular sleep timing, what researchers call social jet lag, produces measurable worsening of insulin sensitivity that operates independently of how much you sleep. Insight number 4, chronic inflammation is a primary driver, and diet addresses it at the source. Okay, stay with me here, because this next one reframes something almost every woman with PMOS has been told, but not fully explained. Most conversations about nutrition and PMOS focus on glycemic index and carb quality, both of which are important, but the inflammatory dimensions of PMOS deserve its own focused discussion, because it operates as both a driver and a consequence of the condition in ways that most dietary advice doesn't fully address. Women with PMOS have significantly elevated markers of systemic low-grade inflammation, elevated hsCRP, elevated TNF-alpha, elevated interleukin-6, that are present even in lean women with the condition, and that correlate directly with the severity of insulin resistance and androgen excess. And this inflammation isn't simply a consequence of metabolic dysfunction. Research published in the Journal of Clinical Endocrinology and Metabolism demonstrated that inflammatory markers in women with PMOS rise in direct response to glucose and saturated fat ingestion, more dramatically than in women without PMOS. This means that each high glycemic, high saturated fat meal produces a disproportionate inflammatory response in women with PMOS that directly stimulates androgen production from the ovaries and the adrenal glands. Reducing post-meal inflammatory response in PMOS requires not just glycemic management, but specific attention to omega-3 intake and polyphenol density, factors that typically dietary advice for PMOS doesn't always address. The dietary intervention with the most direct anti-inflammatory mechanism and the most specific evidence in PMOS is omega-3 fatty acids. A meta-analysis published in Reproductive Biology and Endocrinology found that omega-3 supplementation significantly reduced testosterone levels, fasting insulin, triglycerides, and LDL cholesterol in women with PMOS through direct suppression of the inflammatory signaling pathways that drive androgen production. The dose used in most PMOS trials, 3 to 4 grams of combined EPA and DHA daily, is higher than the standard recommendation for the general population. Polyphenols, the compounds in extra virgin olive oil, berries, dark leafy greens, and green tea, directly inhibit NF-kappa B, the primary transcription factor driving the inflammatory cascade in PMOS. This is the specific mechanism behind the Mediterranean diet's benefit in women with PMOS beyond its glycemic effect alone. Insight number 5, inositol works better than most people realize, but most people aren't taking the right form. Inositol is perhaps the most evidence-backed natural supplement specifically for PMOS, but the nuance around formulation is almost never communicated, and most women taking it aren't taking the form or ratio that the research supports most strongly. Myo-inositol and D-chiroinositol are two naturally occurring molecules that share the exact same chemical formula and sequence, but differ in their 3D orientations that are involved in insulin signaling. In women with PMOS, a specific enzyme, a pyramase, that converts myo-inositol to D-chiroinositol is impaired, contributing to insulin resistance at the cellular level. A comprehensive meta-analysis found that myo-inositol supplementation significantly improved insulin resistance, reduced androgen levels, improved menstrual irregularities, and improved ovulation rates, with an effect size comparable to metformin in several studies, and with significantly better tolerability. The formulation detail most people aren't told is that the ratio of myo-inositol to D-chiroinositol matters. The ratio found in most human tissues is approximately 40:1, and research has demonstrated that this 40:1 ratio produces superior clinical outcomes compared to D-chiroinositol alone, which can paradoxically worsen the features of PMOS at higher doses by depleting tissue myo-inositol. This is available over the counter and is one of the most evidence-backed natural interventions for PMOS, but the effectiveness depends significantly on using the right formulation at the right ratio. To reach the 40:1 ratio, you want 4,000 milligrams of myo-inositol combined with 100 milligrams of D-chiroinositol daily, typically divided across 2 doses. Look specifically for this ratio on the supplement label, not simply inositol as a generic ingredient. So the supplements work, you just have to make sure you're taking the right version. Now, here's one more mechanism most women with PMOS have heard about, but not fully understood. Insight number 6. Stress isn't just making you feel worse, it's directly raising your testosterone. Most women with PMOS have heard that stress is bad for them, but what most haven't heard is the specific mechanism that connects how a stressful afternoon leads to elevated testosterone. Chronic psychological stress activates the HPA axis, producing elevated cortisol, and cortisol has a direct stimulatory effect on 17-alpha hydroxylase, the enzyme in both the ovaries and the adrenal glands that controls androgen synthesis. So elevated cortisol produces elevated androgen output from 2 separate sources simultaneously. Additionally, cortisol directly inhibits the production of sex hormone binding globulin, SHBG, the protein that inactivates free testosterone in the bloodstream. Lower SHBG from chronic stress means more free testosterone is biologically active, independent of how much total testosterone is being produced. And chronic cortisol elevation worsens insulin resistance directly by inhibiting insulin receptor signaling and promoting glucose production by the liver, which then drives further androgen production through the ovary insulin pathway we've already discussed. Stress isn't simply an emotional experience that exacerbates PMOS. It's an active androgen elevating, insulin worsening, SHB suppressing biochemical state. So here are the evidence-based specific interventions with PMOS-specific trial data. A randomized controlled trial published in Fertility and Sterility showed that a structured 8-week mindfulness-based stress reduction program specifically reduced anxiety, cortisol levels, and improved quality of life in women with PMOS. Similarly, a pilot randomized controlled trial published in the Journal of Clinical Endocrinology and Metabolism found that yoga specifically produced significant reduction in testosterone levels, LH to FSH ratio, and anxiety scores in women with PMOS beyond the effect of conventional exercise alone. So stress management isn't a soft recommendation for PMOS. It's an androgen management strategy with clinical trial data behind it. Insight number 7. Evening light exposure is disrupting your hormones while you sleep. Okay, this is the one I promised you at the start. The simplest change on this entire list with one of the most direct connections to the hormonal environment of PMOS. And I saved it for last because once you understand the mechanism, it's impossible to think about your evening routine the same way. Here's what's happening. Melatonin, the hormone produced by the pineal gland in the evening as light levels fall, doesn't simply regulate sleep. While it's circulating overnight, it's telling your ovaries to decrease testosterone production. It's supporting the normal development of your eggs, and it's independently improving how well your body responds to insulin. Three things that are all disrupted by PMOS. Women with PMOS have been found in multiple studies to have altered melatonin secretion compared to women without PMOS, producing evidence that melatonin dysregulation may be an active component of the hormonal disruption, not simply a secondary effect. Now, here's where it gets more interesting. Blue spectrum artificial light from smartphones, tablets, LED overhead lighting, and television suppresses melatonin secretion with a potency and speed that most people underestimate. Light exposure at the intensities present in a typical living room at 9 p.m. delays melatonin onset by 1 to 3 hours, reducing both the duration and the peak of overnight melatonin secretion. For women with PMOS, this means that the standard evening light environment present in most modern homes may be chronically suppressing a hormone that directly supports ovarian function, androgen regulation, and insulin sensitivities every single night. So, 2 hours before your sleep time, transition to warm tone, dim lighting, use lamps rather than overhead LEDs where possible, and avoid screens before bed. But if screen use is unavoidable in the evening, use blue light filtering applications at their most aggressive setting, or wear blue light blocking glasses with lenses rated for evening use. The goal isn't darkness. It's protecting the hormone that's working for you all night if you let it. PMOS, polyendocrine metabolic ovarian syndrome, is a metabolic condition with more than reproductive consequences, and managing it effectively means addressing the upstream causes that standard conversations don't talk about. Here's what I want to leave you with. Your gut microbiome may be actively recirculating androgens. The type of exercise matters more than the amount. Circadian disruption worsens both insulin resistance and androgen production. Post-meal inflammation in PMOS is disproportionately high, and diet addresses it at the source. Inositol works best at the ratio of 40:1. Stress directly elevates testosterone through two simultaneous pathways, and your evening light environment is suppressing a hormone that's working for you every night. That's not a soft list of lifestyle suggestions. Those are upstream levers, and now you know how to use them. If this video gave you something genuinely new, something that changes how you think about managing PMOS, share it with someone in your life who has this condition and deserves this information. Subscribe and leave a comment letting me know what other topics you would like for me to cover. Okay, take care, and I'll see you in the next one.